Okay guys, so we've got a special topic here. This one is going to cover venous ultrasound, both mainly lower extremity, but a little bit of upper extremity also. So start out and just talk about lower extremity venous anatomy. So most anatomists use a convention where they talk about a deep system and a superficial system. The deep system is easy to remember because it has the same naming nomenclature as the arterial system, and in fact the veins are typically accompanied by an artery. The vein's going to be the larger one if they would show them to you side by side. When you get down to the calf veins, typically there's duplication. Alright, so let's walk through them here. So we've got external iliac vein, and then femoral vein. Some people will call that the superficial femoral vein, but remember, this is a pitfall here. The superficial femoral vein is a deep vein, so you can obviously see how that can make a good multiple choice question. Deep femoral vein, popliteal vein, and then your calf veins. So that's the deep system. Now, superficial system is not going to be accompanied by an artery, and probably the only one worth even mentioning regarding the superficial system is the greater saphenous vein. Now, the greater saphenous vein forms along the dorsum of the foot, runs anterior to the medial malleolus, and ascends along the medial posterior-ish leg until it joins the femoral vein just distal to the inguinal ligament. Now, if they want to show it to you in ultrasound, like grayscale, this is there's two ways to do it, so I'm going to show them both to you. This is the first way. So we're going to see you've got two hyperechoic lines here, one that runs over the top, that's the saphenous fascia, and then one runs underneath, that's the thigh fascia, and then the thing in the middle is the greater saphenous vein. Now, some people will say that this looks like an Egyptian eye or sonographic eye sign, something like that. So that's one way to show it. Another way to show it is like this. So we're high up in the leg where the greater saphenous vein is joining the common femoral vein. So we've got three vessels here. Some people, you might look like a Mickey Mouse or something here. So the artery, vein, and greater saphenous vein. So they could put the compression on there, show you like in a cine loop that was the artery, or you could just memorize this. Remember, it's navel, nerve, artery, vein, lymphatics going towards the navel, and I'll show that again later. So next point, this is sort of a little bit of physiology, but it's also normal venous ultrasound theory, Doppler theory. So there's this thing, respiratory variation. It's normal. So it's basically, it happens because of changes in intra-abdominal pressure produced by motion of the diaphragm. So with inspiration, the diaphragm descends, and what happens is you get increased intra-abdominal pressure, which decreases venous flow from the leg. So something like this, okay? And then, with expiration, diaphragm rises, and intra-abdominal pressure decreases, and venous flow from the legs increases, sort of like that. Now, another thing that could be asked or shown is this Valsalva maneuver. So, you're straining, Valsalva maneuver, and you really are increasing pressure here, and you increase it so much that you actually, you poop your pants, right? And then that leads to an actual reversal flow. And so you look at this thing and you say, well, all right, I see that the flow is reversed here, but why did it reversed flow here? Well, then it stopped. Well, why did that happen? Well, let's see here. It happens because of these things. Right here. See, that is the valve. So valves are normal, and they work to prevent like a backflow. So you get this initial jet from pressure, and then the valve kicks in, and it stops that backwards flow. They could show you something like this. They could tell you the patient has performed a Valsalva maneuver, and you notice that there is prolonged reflux. So prolonged reflux with a Valsalva maneuver is a way to show you an incompetent valve or an incompetent vein. This person would be predisposed to varicose veins. All right, so summary here, quick review. So you got respiratory motion that's occurring with increased intra-abdominal and decreased intra-abdominal pressure with respiration, and then you've got a Valsalva maneuver which will actually reverse the flow in the vein, and you should have a normal cessation of flow because of the valve. And then apnea, which is something I didn't talk about yet, you should just have a monophasic waveform. If they tell you the patient has apnea, that would be normal in this situation for there to be a monophasic waveform. And I'll show you a case later on when it's not normal. Okay, so another thing that can be done or talked about here is this idea of augmentation. So this improves detection, helps. So what does augmentation mean? It means that you grab the calf veins and you squeeze, and then if you image like the popliteal vein, you can see like this jet of flow, and that tells you that it's patent. All right, so how do you do these? Hopefully you'll never have to, because they're gross, because you have to you have to talk to patients, which is terrible. B, you have to touch them, which is even worse. And, C, you have to get in their groin, and it's just gross. So, but if they would ask, patients, lay supine, typically elevate the head 20 or 30 degrees. This is to sort of promote venous pooling in the legs. The leg is rotated externally and flexed, the knee, and then you identify the common femoral vein, which is going to be medial to the common femoral artery, and the groin near the crease in the thigh. So remember that it's nerve, artery, vein, lymphatics, navel, going towards the navel. All right, that's the way that I remember it. All right, let's do a couple of cases. So showing you two images here. One is with compression, and one is without compression. So you're noticing that it's not changing, right? So there's a DVT there, but that's not the question. The question is it acute or chronic, and how can you tell the difference? Well, this is acute, and the way you can tell is that it's hypoechoic, almost indistinguishable from normal flowing. So this one's got normal flowing blood in it. It's the artery. And this one is got a clot in it. Well, you can't even see it because it's hypoechoic. The difference is a lack of venous compressibility. That's the hallmark of DVT. That's why you do the compression. All right. But take-home point: acute clot, hypoechoic. All right. So companion case here. Same question: acute versus chronic. And you can see this one's hyperechoic and sort of stringy looking. That's chronic. So thrombus becomes increasingly echogenic with time. Sometimes it's even calcified. It's typically discontinuous and thread-like and that kind of stuff. It might be wall adherent. It's important to mention that DVT is it can be very slow to resolve, and you'll read some places that you can have some residual thrombus, and up to 50% of patients up to a year out. So it can really linger around for a long time. Okay. Next case. All right, this is an anatomy case. So just to orient you here, we're in the upper arm, and we are looking for, let's say we're putting a PICC line in, and they could ask you, what's that? What's that? What's that? What's that? What's that? So we're going to run through it real fast here. So this one that's more medial and sort of up by itself, this is the basilic vein. These two, flanking, Mickey Mouse kind of looking things going on here, these are your two smaller brachial veins next to the brachial artery. That's how to remember that, because they have the same name. And then Deep to that is typically the median nerve, so something like this. So basilic, more medial and fatter, bigger. If they were next to each other, pick the fatter one is going to be the basilic vein. Brachial veins are typically smaller and adjacent to the artery, and then the nerve is going to be deeper. So this is kind of you don't see the nerve here well, so here's another shot. That's the nerve, like the little bundles. That's a normal appearance of the nerve. And this would be a good one also that'd be really tricky to say, okay, which one? This is actually the artery. It'd be hard. Artery, vein, which vein? Well, I'll tell you, this little tiny piece of shit right here is actually brachial vein. And this is actually basilic. If they make you pick, the bigger one is the basilic, okay? Alright, you're going to put a pick line in. Which vessel should you target? Brachial, basilic, cephalic, and this would be a good trick for this. Be careful here, okay? So make sure you read everything. Now, basilic vein. So why? So here's your order of priority. So basilic vein is supposed to be your first target. It's not anywhere near the artery. It's not anywhere near the vein. So if you miss, you're less likely to do damage. The brachial vein is typically the second choice if the basilic was out. The downside is that it is close to the artery and the nerve. Cephalic vein should be your last option. Typically it's only in like fat people. Superficial location, can make it technically challenging, but the real issue is that there's lots of valves and the trajectory is often non-linear, so it can be a pain in the ass to actually get the wire through. Okay, alright, so this is a case where they could show, this is actually in the groin, or they could say which one's the artery and which one's the vein, and they could show you a cine loop. Now it's pretty obvious, right? So this is sort of basic stuff, but just a quick refresher if you haven't done this in a while. The vein is going to compress, the artery is not, okay? You can see that one of them is compressing, one of them is not, okay? So the one that's not compressible is the artery, the one that is compressible is the vein. Alright, so here I warned you there's going to be a case of this. So side by side, common femoral veins, right and left. So you notice the difference is that the right one has that normal respiratory phasicity, okay, and then the left one is monophasic. So asymmetry in the waveforms of the common femoral veins suggests that there's an obstruction proximal, in other words, closer to the heart. So that might be, in this case, IVC, or one of the iliac veins, etc. So that if they show you that, that's what they want you to say. They want you to say central thrombus that's taken the phasicity out here. Alright, last case, this is the last one. Alright, so another loop here, and this has to be shown in a loop. Okay, so what you're seeing here, and then we're going to turn on the vessel this way, sort of looks like this sort of echogenic stuff. Maybe it looks like a puff of smoke. That's a buzzword. Alright, so why does it look like that? Why does it look, is that a thrombus in there? Why does it look like that? So this is slow flow, and it's this rouleau appearance. You can see this with sticky blood. You can see certain conditions, infection, diabetes, cancer, red blood cells stick to each other, and the individual red blood cells are actually sort of causing some reflectors there with the ultrasound beam. So how do you know it's not a clot? Well, you can sort of see that it's moving, but the answer would be compressibility. So if it can compress it, that excludes a thrombus. Alright, that's it. Quick one.